Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z
and John. Well, welcome everybody to MedInsights Unleashed. I'm very, very honored today. We have Dr. Laurie Wirth with us to talk about head and neck cancer. Laurie has been in head and neck cancer and a major global researcher in this area for many, many years. Laurie is a medical oncologist and specializes in thyroid cancer, and that's going to be our subject today. So welcome, Laurie, to MedInsights Unleashed, and we're very happy to have you on the show. So introduce yourself and what you're doing up at Boston.
Sure. So, hi, John. It's so nice to do this with you. John and I go way back. We're old friends. And it's really nice to be able to interact with the MedInsights Unleashed group. So, I am the program director for the new Endocrine Tumor Center at Mass General Brigham Cancer Center in Boston. I'm also professor of medicine at Harvard Medical School. And what I really do is take care of patients with head and neck cancers throughout the head and neck area, but particularly I see a lot of patients with advanced thyroid cancer.
Thyroid cancer, we've been doing a lot of research with you, Laurie, over the years. And just for the patients and people listening to this, there's over 800,000 patients are diagnosed globally a year. 44,000 of those are going to be newly diagnosed in the United States, 57,000 in the North American region. One of the areas that we hear a lot about in thyroid cancer, that this is a good cancer to have because the survival rate is about 98%. But as we know, thyroid cancer or any cancer is not a good cancer to have. Can you talk about why the survival rate is so good, why we really don't want people to say that this is a great cancer to have?
Yeah, that phrase has always stuck in my craw because I agree with you completely. There is no good cancer. There are cancers that are different from one another, but any cancer diagnosis is difficult for patients, including a thyroid cancer diagnosis. But the reason why it has that good reputation is because most thyroid cancers, when they're found and identified, they're early stage. And most thyroid cancers are very indolent in nature, so they tend to grow very slowly. So there's plenty of opportunity to treat most thyroid cancers effectively, mostly with surgery. Some patients with thyroid cancer will benefit from radioactive iodine as well. And most people with thyroid cancer will survive their thyroid cancer, will outlive their thyroid cancer, even if it isn't completely cured, which many are. Still, many patients will live a completely normal life alongside their thyroid cancer without their thyroid cancer making them sick. There is a flip side to the coin, however, which is that not every thyroid cancer behaves itself like that.
We're dealing mainly through our research into three areas: differentiated, medullary, and anaplastic thyroid cancer, anaplastic being the worst prognosis. Can you talk about the three?
Sure. Well, and you listed them in order of frequency as well. So you're very organized today, John. But so differentiated thyroid cancer is by far and away the most common type of thyroid cancer that we see. That is subdivided into several different subtypes of differentiated thyroid cancer, such as papillary thyroid cancer, follicular thyroid cancer, oncocytic thyroid cancer. But all of those cancers basically are well differentiated thyroid cancers. The cancer cells under the microscope look a lot like the normal thyroid cells, and they have shared features with normal thyroid cells. Most of the well-differentiated thyroid cancers are indolent in nature, do grow very slowly, and when identified, most patients will do quite well with surgery, and surgery can be less extensive or more extensive based on how much disease there is in the thyroid gland and the lymph nodes. And then after surgery, many patients will be treated with radioactive iodine. We used to treat everybody with a total thyroidectomy, gave everybody radioactive iodine. That's now changed because we now recognize that many people will do well with less surgery, and many patients don't even need to have radioactive iodine. So most people with differentiated thyroid cancer will do well over time. Most patients don't develop advanced disease that's going to make them sick, but that does happen in a small set of those patients. So that's differentiated thyroid cancer. Medullary thyroid cancer is uncommon, but it's the next most common type of thyroid cancer overall. It's very different from the other thyroid cancers. Medullary thyroid cancer arises out of what's called the parafollicular C cell, which just happens to sit in the thyroid gland, but that cell is very different from the other normal thyroid cells. And so medullary thyroid cancer that arises out of that parafollicular C cell also is just very different than the other differentiated thyroid cancers. So there's a totally different biology. Most people with medullary thyroid cancer will also be diagnosed when they still have early stage disease, and they can be treated effectively with surgery alone. Radioactive iodine has no role in those patients at all. Medullary thyroid cancer is a higher risk cancer than differentiated thyroid cancer, so there's a higher risk of the cancer coming back with the diagnosis of medullary thyroid cancer. And then the last one, in terms of the big categories, is anaplastic thyroid cancer. Anaplastic thyroid cancer is unfortunately one of the most aggressive types of cancers that we see in oncology. It tends to grow very rapidly, both in the neck area as well as spread distantly to other parts of the body. And anaplastic thyroid cancer can be difficult to treat. Many patients won't have operable disease at the initial presentation. Many patients will have metastatic disease when they're initially diagnosed. Unfortunately, a subset of those patients have new therapies available that we can talk about more. So the prognosis, even for that worst category of thyroid cancer, has gotten a lot better in the last 5 to 8 years, as has the prognosis for all of the other patients with advanced thyroid cancer.
So the prognosis is improving, the diagnosis is earlier. So I was looking at the Sears data, and obviously we're tailing off with growth in thyroid cancer in the United States, but it is growing outside of those areas where there's active surveillance programs.
Hey, John, can I just say something about that? Because that's actually a really important point. And so what you're talking about is the fact that doing surveillance for thyroid cancer leads to overdiagnosis and identification of too many small, very slow growing lesions in the thyroid gland that never needed to be diagnosed to begin with. And so there's a reservoir of people out there who actually do harbor very tiny, clinically insignificant thyroid cancers that are never going to cause any harm, never going to cause any illness to the patient. And if we do a surveillance approach to find every single thyroid nodule in every single patient, we'll overdiagnose thyroid cancer and we'll overtreat thyroid cancer and cause people harm by doing that. So in the developed world, there's been a real recognition that overdiagnosis has been a problem. And we've cut back in our diagnostic workup for people with very small thyroid nodules that might be found incidentally, like if somebody's in a car accident and they have a CT scan to make sure that they haven't broken their neck. And then on the CT scan, if you see an 8 millimeter thyroid nodule, we don't biopsy those any longer. They may need to be followed, but around the world, there's a growing recognition of the problem of overdiagnosis. So most places that have been doing surveillance have gotten the memo and are no longer doing surveillance so that we're not overdiagnosing and overtreating people.
That's a great point. I was going to ask you about active surveillance. So when people are diagnosed with these very small insignificant tumors. I suppose there's no such thing as an insignificant tumor, but how do they fall into follow-up?
Yeah. So as a corollary to the overdiagnosis story, we now have the active surveillance story. So that's the perfect segue, John. So this practice was first instituted in Japan. And so the Japanese really pioneered the idea of not overtreating every single patient who has a very small thyroid cancer. So now in Japan, it is the standard of care to, if patients are diagnosed with a small thyroid cancer that might be 1 centimeter in size, no abnormal lymph nodes, a differentiated thyroid cancer, those patients can be monitored with ultrasound and only undergo surgery if there's meaningful growth in that nodule over time. And so there are other places now that have adopted this approach of active surveillance as well. And now in the new ATA thyroid cancer guidelines that was just published a couple of months ago, there's a very clear guidance for active surveillance for patients with small thyroid cancers that don't have high risk features present. And when those nodules do change and grow, then they need therapy. If the nodules don't change and don't grow at all, then those patients can avoid a surgery that can have some potential downsides for them. And it's really only a minority of patients who are in active surveillance who actually have to go on and have surgery. So that's a big leap forward.
Talking about earlier diagnosis, one of the areas that we teach people is doing the butterfly test around your neck and looking for lumps in the mirror. Is that still a go before we get into the diagnostics and biomarker tests? How do people look for potential tumors in their throat for that active surveillance program if they don't end up in a AE or ER and have that CT scan for their
Right,
back and
right,
find
right,
it?
right. Well, it's preferred that a patient just notices a lump in their neck than undergoes than happens to have a car accident for sure. So I think that one thing that's important is that we all have lumps and bumps present. You know, there are lymph nodes that people can sometimes feel under their jaw or in their neck area or in their underarm or in their groin area. And a lymph node that is smaller than the size of a grape could very well be a normal thing. But lumps that are hard and bigger than a walnut might not be normal. And those are the kinds of things when people notice them that should always be brought to their care, the attention of their PCP or their GP. And so there is the thyroid gland does sit in the lower part of the central neck, in the middle of the neck. And so a lump there, either right in the middle or on either side of where the collarbone, or where the head of the collarbone is something that could be an abnormal thyroid lump. And then the lymph nodes in the neck generally run along from the angle of the jawbone down to the collarbone. And so enlarged palpable masses in that area are potentially abnormal. So a common scenario where patients notice those things themselves is men who are shaving who suddenly feel that there's a lump in their neck. When that happens, you should see your GP or your primary care physician.
So women are 2/3 versus men. Is there a reason why women get the disease more often than men?
I don't know why that is the case, and I have asked really smart people, and it sounds like you might have asked people as well, and, I've actually never really even heard of a really good hypothesis that sounds, like it could be right on. Of course, there are the hormonal differences between men and women. Is estrogen, for example, somehow a promoter of thyroid cancer cell growth? There is no evidence of that I'm aware of. And or is testosterone protective? It doesn't really make sense. And there isn't any evidence that I know of. But it isn't just a diagnostic bias where women are more likely to get diagnosed with a thyroid cancer than men are by undergoing screening or diagnostic imaging. So that doesn't explain it. I think that there really is a true incidence difference with thyroid cancer being more common in women than men. Especially that's true in younger people. So in the age group of 40 people or younger, there's a strong female predominance. And then things even out a little bit in the older patient population. And then that's also the patient population where thyroid cancers can become a little bit more or a little bit less indolent than in thyroid cancers that are diagnosed in younger people.
Thanks for that, Laurie. You've been involved in all the leading trials in thyroid cancers globally now for many years, and that was part of my introduction. With RAI being used in differentiated thyroid cancer as a standard therapy, what's the treatment algorithm for a patient who's newly diagnosed with differentiated thyroid cancer? We talked about medullary and anaplastic. Can you take us through the steps of treatment for each of
Yeah,
those?
sure. I can tell you were trying to say medullary with your
It did.
Australian accent. When I'm in Australia,
I
I try
mentioned
so hard to say medullary.
I know, I just, different
But anyway,
university maybe.
yeah. So with differentiated thyroid cancer, after a patient, say, would have a thyroid nodule detected, a fine needle aspiration is usually done, and in many patients, a fine needle aspiration can lead to the definitive diagnosis that this is a papillary thyroid cancer. So the next question is what is the best surgery for that papillary thyroid cancer? Or is it a really small cancer that where the patient doesn't need to have surgery now? And if active surveillance makes sense to the patient and their physician, then they can enter into a period of active surveillance. But let's say active surveillance that it's bigger nodule and active surveillance is not appropriate. Then the next decision is what kind of surgery does a patient need to have? Do they need to have a total thyroidectomy and have some lymph nodes be removed as well? Or do they not need that extensive a surgery? And can they only have a hemithyroidectomy and leave the half of the thyroid in place? So we've de-escalated in terms of our surgical approach for some patients as well. If patients have low volume disease and they only need to have a hemithyroidectomy, then in general, those patients don't need to have radioactive iodine. They just need to have appropriate follow up. So usually patients are followed in the United States by endocrinologists after they've had their surgery. Some surgeons will follow their patients as well. And then for the patients that have more disease, and have a total thyroidectomy, then in general, those patients will go on and receive a dose of radioactive iodine. And the dose can vary depending on the risk features that are present coming out of the surgery. Then usually patients will enter a period of follow-up. It's in the US, it's usually done by endocrinologists, and they'll be followed for evidence of whether the thyroid cancer is coming back or not. Usually that follow-up is with blood tests and with ultrasounds of the neck. So it's only a small subset of patients who, with differentiated thyroid cancer, whose cancers will come back, either in the neck area or with distant metastatic disease. Then we'll make a determination about whether those patients would benefit from more radioactive iodine treatment, more surgery, or not. If not, then patients may ultimately need the other systemic cancer therapies that are the kinds of treatments that we give in our medical oncology clinic. So we don't necessarily call them chemotherapy because that brings to mind IV chemo that, say, women with breast cancer get, for example. I like to think about these more as, for the most part, oral cancer drugs that we use when people have iodine refractory metastatic differentiated thyroid cancer. But even not all of those patients need to have treatment because many of those patients will have slow growing disease, and we will monitor those patients before starting treatment. So it's a small subset of patients with differentiated thyroid cancer, whoever, end up in that category of more advanced disease. Most people will have surgery, plus or minus radioactive iodine, and then some follow-up and a little bit of other endocrinology treatment over time, and most people will do incredibly well. For medullary thyroid cancer, this is a very interesting disease because I mentioned it's unique. It's very different than the differentiated thyroid cancer. So one of the things that's unique about medullary thyroid cancer that's really important is that about 25% of the cases are inherited by inheriting a RET mutated gene from either the mother or the father. It's really important to identify patients who are newly diagnosed with medullary thyroid cancer who have an inherited RET gene, because that means that those people are at risk for harboring some other endocrine cancers, and their family members could also be at risk for harboring that inherited gene. A workup to determine whether or not somebody has an inherited RET gene is part of the initial diagnosis and workup for people with medullary thyroid cancer. And people then generally, for the most part, will have surgery. And then after surgery, patients are followed because there is a slightly higher risk of recurrence over time. And so that can be done in general by endocrinologists. When patients do have recurrent metastatic disease, then again, we consider them to have advanced medullary thyroid cancer. And then we begin to start thinking about our medical oncology oral cancer drugs, which are now highly effective at treating people with advanced medullary thyroid cancer.
And the anaplastics?
So with the anaplastics, it is a setting where things move so rapidly. The doctors are all calling each other on their cell phones saying, I think this patient might have anaplastic thyroid cancer. Can you look at the scans? When can you see the patient? I've got a biopsy scheduled for tomorrow. What kind of a biopsy should I do? So we really try to get the patient in, get the workup done as soon as possible. We want to get a biopsy done as soon as possible. And when we're doing the biopsy, we want to make sure that we're doing a big enough biopsy so that we can look at the genes in the anaplastic thyroid cancer right away. We don't want just a piddly little fine needle aspiration for people with anaplastic thyroid cancer. We want to do a core needle biopsy or even an open biopsy if we suspect that it's anaplastic thyroid cancer, because we want to know what's in the genes and we want to know that as soon as possible.
Talking about the genes, we hear a lot about BRAF and V600, RAS, RET, PTC, TERT, and fusion inhibitors. So what is all this to a patient, and how does it fit into the story of thyroid cancer?
Well, this is really the story of thyroid cancer that has unfurled over the last 10 years. So what we've learned is that thyroid cancer really is the poster child for cancers that harbor potentially actionable, druggable gene alterations. And that sort of is a mouthful. But basically, the last 15 years, 20 years in oncology, one of the major trends has been in identifying these druggable gene alterations where some either gene mutation or gene rearrangement acts as a driver mutation that drives the cancer. And if you can come up with a drug that blocks that driver alteration, you've got a great cancer drug. One of the first drugs was Gleevec in CML and in GI stromal tumors that blocks the KIT kinase. And then one of the other early alterations was EGFR mutations in lung cancer. So it turns out that across the array of thyroid cancer diagnoses that we talked about, we have a very high percentage of patients that whose cancers harbor potentially actionable driver gene mutations or gene rearrangements. So we see them in differentiated thyroid cancer, we see them in medullary thyroid cancer, and we see them in anaplastic thyroid cancer. And so when those gene alterations are present, we've got a good drug for that for the most part. And so the genomic makeup of an advanced thyroid cancer has now become a critical thing for us to understand before we start thinking about what the best treatment approach is for the patient so that we can understand, is there a precision drug for this particular patient, or should we use a drug that isn't so precision targeted and use a drug that will work regardless of what the genomic makeup is? So in papillary thyroid cancer, the most common mutation that we now know is present is that BRAF V600E mutation. And there are drugs that were initially developed to treat melanoma because that mutation is common in melanoma. So we've finally just recently completed our first randomized phase 3 trial of dabrafenib and trametinib in radioactive iodine refractory papillary thyroid cancer harboring a BRAF V600E mutation that has progressed the first line therapy with a multikinase inhibitor like lenvatinib or sorafenib. So that study was just presented at ESMO in Berlin 2 months ago. And so dabrafenib and trametinib were compared to placebo. And actually the activity in the second line setting of that combination was really very good. So we have now really good data that supports the use of dabrafenib and trametinib following initial therapy with a drug like lenvatinib for patients with the BRAF mutated papillary thyroid cancer.
What would be the incidence of patients with BRAF V600?
So about 60% of
Wow.
people with papillary thyroid cancer have that mutation. So there's a high hit rate. So yeah, it's definitely wealthy. And because of that, that means that everybody really should have genotyping of their tumor done because the hit rate is so high. And then it's also really important to know that about 30 or 35% of anaplastic thyroid cancers also harbor a BRAF V600E mutation. And those patients can have really good responses also to dabrafenib and trametinib, which is FDA approved for BRAF mutated anaplastic thyroid cancer. So you really want to know the BRAF status for both of those two diagnoses.
The story for the patients or the doctors listening to this show is that they really need to go to a center that's got the multidisciplinary team that can actually analyze these patients correctly and do the right test.
So I think that that's a good message, although not everybody has, a big thyroid cancer program right down the street. People live in rural places and don't all have the luxury of traveling to a big program, a big referral center. One thing I think that's important for patients is to be aware to ask lots of questions and never be shy to ask their doctor lots of questions and to say, hey, what about that BRAF mutation? I heard that that's a big deal in thyroid cancer. Has my cancer been tested for that? Has my cancer been tested for the genomic mutations that can be common in thyroid cancer? And if not, can we do that? And then the other thing is that, people who are like me who, I have such a narrow world of expertise, but it is a deep expertise. I'm always happy for people to reach out to me, other doctors to reach out to me and say, hey, I've seen thyroid cancer once before in my community oncology practice. This is the patient. And what do you think about what I was thinking about doing? So, we're all really happy to all help each other out as much as possible. But having consultation in a referral center, if possible, can be helpful because advanced thyroid cancer is definitely an uncommon disease. And there are a few things that we don't want to miss. So another example of something that you don't want to miss in somebody with an advanced differentiated thyroid cancer is the RET gene rearrangement. So That now is really important because we have a drug for that. So about 10 to 15% of advanced iodine refractory papillary thyroid cancers will harbor a RET gene rearrangement, where the RET gene gets rearranged with another gene, and that causes an abnormal fusion protein that's a driver alteration in those cancers, and that's druggable there have been 2 drugs that have been FDA approved, selpercatinib and pralsetinib in the US are both available. The drugs are available in different circumstances in different countries. They're not both available around the world, unfortunately. However, those 2 drugs are highly effective in those RET gene rearrangement thyroid cancers. And 10 or 15% is not a rare thing, you know? And then also, it's really important to know that those fusions or gene rearrangements are even more common in younger patients. So we don't want to miss the fusions in older patients too, but we definitely don't want to miss those gene rearrangements in younger people.
There's a new terminology that is creeping into thyroid cancer, or maybe it's not creeping in, maybe it's been there all the time, but I was reading about it. The tumor mutational burden being high and immunotherapy. How does this fit into your day-to-day diagnosis and treatment of patients?
Well, I can tell you that it's really it has creeped in, although I think that I know the reason why, and it's not a good reason why. So in the NCCN guidelines, the National Comprehensive Cancer Network guidelines, it's a panel of institutions that are all part of the NCCN network and the NCCN network has guidelines panels for each tumor type, head and neck cancer, lung cancer, thyroid cancer, and so forth. And those guidelines are available online. They're very user-friendly for physicians to go to them quickly when they've got a patient in a room and they have to look something up. So they're very impactful. We don't see high tumor mutational burden very often in thyroid cancer at all, and almost never in differentiated thyroid cancer, almost never in medullary thyroid cancer. We can see it uncommonly in anaplastic thyroid cancer. However, if you look in the NCCN guidelines and see what kind of molecular testing or genetic testing should you be doing in thyroid cancers, it will say you want to look for the mutations, gene rearrangements, and you want to look for high tumor mutational burden. The reason why is because pembrolizumab has tumor agnostic FDA approval for any cancer that has a high tumor mutational burden. So if I happen to stumble upon somebody with an advanced iodine refractory differentiated thyroid cancer whose cancer did have a high TMB, then pembrolizumab is FDA approved for that patient. But we really shouldn't have included that in the NCCN guidelines, in my opinion, because we just don't see high TMBs in the vast majority of thyroid cancers. I look for it in anaplastic thyroid cancers intentionally, and then it actually comes on the panel that I order for my multi-gene testing, so I see it and it's always low. So, but I've actually been arguing that should come out of the NCCN guidelines, and I haven't won that argument yet.
I don't see you losing too many arguments in my time. The future. My last discussion with you was neoadjuvant trials going on with 5 big centers, your center and Greg's center being the lead for neoadjuvant therapy in thyroid cancer or head and neck cancer. How is that panning out? What's happening from a neoadjuvant perspective and curative intent?
I'm glad you asked. That is one of our pet projects at Mass General and Massachusetts Eye and Ear Infirmary. So Greg Randolph, who's thyroid cancer surgeon at Mass Eye and Ear, this is really his baby, his project. And I've been helping provide medical oncology expertise for the study. So basically what we've done is taken a look at neoadjuvant lenvatinib cancer treatment for people who have differentiated thyroid cancer who present with either really bulky disease to begin with. 'Cause sometimes people will just not realize that they've got a big tumor growing in their neck. And by the time that somebody finally realizes, wow, there's a big tumor there, it can just be kind of too big to operate on easily. Or sometimes thyroid cancers might not be big, but they're more invasive than usual. And they're invading local structures that we don't want cancers to invade, like the windpipe or the trachea, or the nerve that moves the vocal cords, or growing around the carotid artery. So those cancers, prior to our interest in neoadjuvant treatment, the surgeons would remove as much of the cancer as they could, but often they would have to leave what we call gross disease behind, which is not that it's gross, but that the surgeon has to leave a lump of cancer behind that they can see. Not just microscopic disease, but they have to leave some tumor behind, like on the wall of the trachea or windpipe, because if they removed any more, there'd be a hole in the trachea. So not in the old days, but before thinking about neoadjuvant therapy, the surgeons would leave some gross tumor behind and hope that radioactive iodine is going to clean it up. In those cases, radioactive iodine tends to not work as well when the cancers are really invasive like that. It's not really a great idea to rely on radioactive iodine cleaning up those lumps of cancer that are left behind. Then the other little thing to think about in terms of story unfolding is that lenvatinib is a drug that works really well in people with advanced thyroid cancer. The objective response rate is 65%. So most people who have that diagnosis will respond quite nicely to lenvatinib. So when Greg Randolph, went to my umpteenth talk about lenvatinib, one day it finally dawned on him, oh, wait a second. If we can shrink up tumors significantly in 65% of patients with advanced thyroid cancer, what if I give that drug to people who present with that more invasive cancer to begin with? Can we do that? And then can we do more optimal thyroid cancer surgeries so that we can less frequently leave that gross tumor behind, so that the cancer outcomes will be better and so that the surgical outcomes will be better? Can we save some of those nerves that the cancer is sitting right on top of, so that to maintain or to regain vocal cord function? Can we leave that trachea intact without having to remove part of the tracheal wall to get all of the tumor out? We just completed a multi-center neoadjuvant trial with lenvatinib, and Dr. Randolph presented it at the American Thyroid Association meeting a couple of months ago. And data are not finalized. We actually were just meeting with the study team today, data team. So we're putting together the final data cut, and we'll be working on the manuscript soon. So there's more to come in this story, but the results that Greg presented to ATA looked really promising. And the surgical field is very interested in the idea of neoadjuvant therapy having a role for that small subset of patients who present with more aggressive tumors to begin with.
Well, I'll be really looking forward to hearing and seeing those results, and maybe we can get Greg to come back on MedInsights Unleashed and present and talk about the data. It should be.
I'm sure you could get Greg to talk about neoadjuvant therapy in thyroid cancer.
Yeah, I was so proud to be involved in that study.
Yeah.
It's really good. Talking about studies and research, what's next for Professor Laurie Wirth in thyroid cancer? What are you doing from a research perspective at Mass General?
Well, so one of the things about doing research in advanced thyroid cancer is that it's very difficult. So we've got really good first-line therapies for people with RAI refractory differentiated thyroid cancer for metastatic medullary thyroid cancer. And when you have first-line therapy that works really good in a lot of patients, it's really hard to come up with something that's gonna be better than that, and so it's a good problem to have in a way, but we always wanna do better, but it does make that challenging. So I think for the most part in the field, our focus really is on what do we do with patients when their cancer starts to grow again? Because for the most part, these systemic cancer drugs that we have don't cure the cancer completely. We can get a lot of mileage out of helping keep people alive longer, keeping their disease in check. But for the most part, when people have metastatic disease, our drugs alone right now don't completely cure the cancer forever. So eventually, for most people, the cancer will start to grow again. So we're really focusing on that second line therapy. So one of the things that we're doing at Mass General is looking at new approaches in the second line therapy for people with medullary thyroid cancer. We've been exploring a new treatment there, and hopefully we'll have an early publication out soon. That there are a couple of targets in medullary thyroid cancer that have drugs that are in development that are worth going after. So hopefully there will be some clinical trials in that space in the coming, 6 months to a year. But these things are still very nascent, I'd say. Another area where we really need to figure out how to leverage is in immunotherapy for people with thyroid cancer. So our immunotherapies that we use in a lot of other solid tumors really don't seem to have that much activity in most of the advanced thyroid cancers. We do see immunotherapy being active in a subset of anaplastic thyroid cancers, and that can be a real home run for a subset of patients. And so there's definitely a role there. But we're working on trying to figure out how to leverage everything that we've been learning about in terms of the role of immunotherapy in the solid tumor space over the last 15 years for our patients with thyroid cancer.
Do you see combinations being used up front earlier, or do you see them in those resistant cases in the second line setting? How is combination therapy progressing? You've got combinations with lenvatinib, you've got combinations with dorafinib. What makes the decision between one versus the other?
Yeah, well, so, ultimately, in order to figure this out for the patient population, we have to be able to do randomized phase 3 gold standard trials. And again, it's very difficult to do that because with the lenvatinib example, for example, it's hard to design a combination of lenvatinib plus something else and get it to work better than that overall response rate of 65%. And if we have a promising combination, then we need to do a clinical trial that has not 400 patients in it, but we need to do a clinical trial that has 1,000 patients in it. And to be able to do that kind of a clinical trial internationally that, has the chance of providing good definitive data is something that is simply not feasible
Yeah, it's
in the
not
thyroid
feasible.
cancer space. It's different if you're talking about adjuvant therapy for people with breast cancer, which is a much more common diagnosis. And, it's the ability to do clinical trials with 1,500 patients with breast cancer is something that is feasible. It's just not feasible with thyroid cancer because of how uncommon the diagnosis is. And that's one of the challenges that's very difficult in terms of advancing the field forward with clinical trials because this is a rare patient population. So there are hurdles for doing clinical trials in rare patient populations.
Would randomized phase 2s be suitable? You know,
Sometimes yes, and that sometimes will work, especially for patients in the US. So, you know, generally the bar for access to drugs is higher outside of the US. because of the way that, for example, the EMA approaches drug approval compared to the FDA. But then also in the US, we can sometimes gain access to cancer drugs in an off-label setting where that particular drug doesn't have an FDA approval for that particular diagnosis, but we've got pretty good data that the drug does work in this diagnosis, and sometimes insurers will cover the drug. And we can get those data sometimes from randomized phase twos, and that can help with access. And that's one of the reasons why the NCCN guidelines are so important, because the NCCN panel will say, you know what, that was a really well done randomized phase 2 trial that showed that it really does look like this combination works better than that single agent. And we think that this is something that we would use in our patient population if we can. And then once there are recommendations for a particular therapy in the NCCN guidelines, then it's more likely that providers can get insurance coverage for those expensive cancer drugs.
Thank you for that. You're one of the leading researchers and patient carers for thyroid patients for years now. And you're one of the doctors that really looks after the patient personally throughout the years that I've known. How does your patients follow up? Are there advocacy groups that they can go to seek further support from your side? I know your team up at Mass General is an amazing team that really follows through on the patients, but there's also advocacy that's needed to support the caregivers and the patients. So do you want to talk about that?
Yeah, so I'm so glad that you're bringing that up, and thank you for your kind words. You're too kind. But I'll take
You're a
those
mentor.
compliments. I'll take those compliments back to my team, because it really does take a team to take care of people, and I've got a great
Right.
team, and
Yeah.
I rely on them, and my patients do too. So I think that the most prominent patient advocacy group is THYCA, capital THY, capital CA, and I don't know how many years ago THYCA was established, but THYCA was established long before COVID, long before everything was done on the internet. And it's actually there are international groups within THYCA, and then across the US there are THYCA chapters. There's an annual meeting in the US that always now has a virtual component as well for patients. And they have a great website, and they have support groups that are available for people, and just tons of patient-friendly information that's available on the websites, and then also at that annual meeting. There is another patient advocacy group called THANC, THANC, that was first established by Mark Erkin, who's a head and neck thyroid surgeon at Mount Sinai in New York. And so THANC has a really good website and provides patient advocacy through their program as well. There's also a guidelines aspect to THANC that's available for providers. There's a Friday morning online conference on thyroid cancer that's really widely attended from around the world. That's a great resource as well. And there was a third thing I was going to say, and now I can't remember what it was.
It's all right. But these advocacy groups have got enormous resources and patient support materials
Yeah,
for
yeah,
your patients, which
yeah.
is
You know,
amazing.
I was actually, now I remember what I was going to say. So the other thing is, there are, patients have gotten together and created their own support groups. And so, for example, there's a medullary thyroid cancer patient support group that I think that it's a Facebook support group, or a Facebook group with people and their family members with medullary thyroid cancer. And I myself am not part of it, though I know a lot of thyroid cancer physicians are part of it, but I hear a lot about it from my patients. And I think that patients really love to help each other out, and that format, I think, is really wonderful for a lot of people as well.
So, Laurie, we're coming to the end. Can you just give 3 to 4 bullet points of your thoughts about thyroid cancer for the patients and the caregivers that are listening to this episode to sum up your thoughts about the treatment, about care, about the questions, about advocacy?
Sure. Well, so one thing that I have said before is I really like to quote Bob Gagel when I'm thinking just in general about my life in taking care of people with thyroid cancer. This was a comment that he made at the FDA a couple of decades ago when vandetanib was being considered by the FDA for medullary thyroid cancer. And I was there as part of the team, and Bob gave opening remarks on medullary thyroid cancer. One of the things he said is that most of our patients live for quite a while and we see them frequently. And so, it's such a privilege taking care of our patients with thyroid cancer because so many of them become our old friends. And that's really been true in my life. And it is a remarkable privilege and something that, you know, 25 years ago when I was just starting out in my career, I wasn't thinking, was going to be a big deal in my life. And that is a really big deal. And Bob Gagel really captured that so well. So, I think that the important thing is that many people with even advanced thyroid cancer will be around for a long time. And getting the treatment right is so important because we can sometimes harm people with treatment. And sometimes the risk of us intervening isn't appropriate. Sometimes we do need to take risks with our interventions because the disease warrants it. But the treatment really needs to be personalized for what that individual's thyroid cancer is like, and then also often what is most important with the patient. So we really, this is a time when we really need to be thinking that not only is thyroid cancer a poster child for precision treatment, but it's also a poster child for shared decision making. So we want to make sure that we're giving just the right treatment to just the right patient at just the right time. And part of that is for advanced thyroid cancer, knowing the gene makeup in the cancers. We want to make sure that we know that before we start the treatment.
One thing we never did discuss, and you did bring it up there with treatments, and is adverse event. I mean, we're not going to go through every adverse event of all the drugs that we've mentioned, but just in general, from an adverse event side, what should patients be doing and following up? Because I know your phone runs hot and that your staff in educating patients about adverse events.
Yeah, well, that's why the team is so important because people who are on oral cancer drugs for advanced thyroid cancer will have some adverse events. These are cancer drugs. So when people have high cholesterol, they usually feel fine when they're taking cholesterol medicine, or high blood pressure, you feel fine taking your high blood pressure medicines. But cancer drugs will have side effects because we've not yet been able to figure out exactly how to hit only cancer cells with drugs and leave the normal cells completely untouched. So different thyroid cancer drugs have different adverse event profiles. Some of the cancer drugs will have a longer list of adverse events. So, and then the highly precision therapies tend to have more narrow list of adverse events, but those adverse events can still be difficult for patients. No matter what no matter if it's a multikinase inhibitor or one of the precision drugs, what we really need to do is optimally manage the patient to get ready to take the treatment. So with lenvatinib, for example, hypertension is the most common adverse event. So before we start lenvatinib, we have to make sure that the patient's blood pressure is well controlled and that they're starting to take their blood pressure on a daily basis before they start lenvatinib, and that they know when to call us if and when it goes up so that we can initiate antihypertensive therapy right away when we see that adverse event happen. The management of adverse events starts with the consent process, starts before the patient even starts taking the drug. So we really need to make sure that we're spending plenty of time going over what patients can expect, what hopefully won't happen, but is a potential rare complication of a treatment drug. Make sure that, they're well armed with information before they start, and then go over the same things over and over again in clinic when we're seeing the patients, and make sure that the lines of communication are open.
Well, Laurie, I can't thank you enough on behalf of all the listeners on MedInsights Unleashed. This has been a phenomenal talk about thyroid cancer and presentation about the data. It's just amazing. So can't thank you enough from the bottom of my heart on behalf of all our listeners. Really amazing. Thank you, thank you, thank you.
Oh, well, thank you very much. Thank you for having me, John. And thanks to MedInsights Unleashed and to all of you out there for listening.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.